Stress, urinary incontinence, and the use of bulkamid. This presentation is based on a nice review article which was published in the Obstetrician and Gynecologist on March 2020. This presentation and the article represent the management of stress urinary incontinence in view of the NICE guideline and the recent evidence-based practice. So what is urinary incontinence in general? Urinary incontinence is defined as any involuntary loss of urine. We have two main causes of urinary incontinence, which are stress urinary incontinence, which is our topic today, and urge stress incontinence. Also, there is mixed urinary incontinence. The most common type of incontinence is the stress urinary incontinence, which is involuntary loss of urine associated with effort or exertion, like sneezing, coughing, and exercises. While urgency urinary incontinence, or as the common name, which is overactive bladder. However, there is always a misnomer of the overactive bladder, because overactive bladder is further subclassified into dry and wet. The dry one represents the symptoms of frequency, urgency without incontinence, but the wet subtype classified as urgency, frequency plus urinary incontinence. And urge urinary incontinence is involuntary loss of urine precipitated by severe urgency to micturate. And usually we ask the patient, are you able to reach the toilet when you have the sensation without leaking? And the patient will say, no, she has to leak before. This describes the urge urinary incontinence. If we go for the pathophysiology of stress urinary incontinence, stress incontinence happen due to two main reasons, either urethral hypermobility or intrinsic sphincter deficiency. Urethral hypermobility, to understand that during a stressful event like sneezing or coughing, there is an increase in the intra-abdominal pressure. When the increase in the intra-abdominal pressure happens, it transfers to the urethral pressure. So usually the increase in the urethral pressure is much more than the increase in the intra-abdominal pressure, and this keeps the urethra closed. This is usually supported by the cushion mechanism from the vasculature around the urethra, the muscles, the attachment of the ligaments, the vaginal wall, and the pelvic floor, which all support this mechanism to prevent leak. However, in event of labor with pelvic floor damage during a childbirth, there is loss of that support, especially which provided by the pubourethral ligament and the anterior vaginal wall. So once the support is lost, the increase in the abdominal pressure during sneezing and coughing overcome the urethral pressure, and leak will happen. And this hypermobility usually demonstrated when there is descent and anterior rotation of the anterior vaginal wall. In the past, we used to do something called the Q-tip test, in which we insert a cotton tip swab in the urethra and then ask the patient to contract its pelvic floor muscles. If the angle of the mobility of this cotton tip swab from the horizontal plane is more than 15 degrees, it's diagnostic for the urethral hypermobility. This test is no more done nowadays because it's proven of its lack of sensitivity and inefficiency for diagnosis. The other one is the intrinsic sphincter deficiency, which is caused mainly by the primary urethral weakness. And this occurs absent of any urethral hypermobility. And again, in examination, the urethra will appear fixed or rigid. Intrinsic sphincter deficiency usually happens in women after failed surgery for stress incontinence. However, although there is that classification, it is usually mixed together, and it's difficult to in clinical practice to identify which is the main reason for stress urinary incontinence, and in most cases it includes both etiologies together. So if the patient history and examination confirm stress urinary incontinence, then there is no need to do urodynamics at this stage. However, you need a bladder diary, because bladder diary will show the amount of uh, the bladder diary is a true reflection of the bladder through 24 hours. So this diary will show how much water the patient drank or any drink she can have, how much urine is coming and how frequent she goes to the toilet. It can show that it is frequency, it is a low bladder volume, so the bladder cannot withstand an increased amount of urine. Also, it shows when the leak happened and what predisposed to the leak. There is a useful British Society of Urogynecologists bladder diary, which we use for the patients. And it's very important that the patient fill 3 days of bladder diary before reaching a stage of treatment for stress urinary incontinence. For stress incontinence, the first line of management would be lifestyle modification. So we ask the patient to reduce weight if her BMI is more than 30, stop smoking, reduce alcohol intake, increase exercises every day, at least 30 minutes. And it was shown that these lifestyle modifications help a lot of patients with stress incontinence. We provide that with the bladder healthy diet. Again, there's a very useful British Society of Urogynecology leaflets about healthy bladder diet that will ask the patient to avoid drinking tea or coffee, acidic juice, and we encourage to have decaffeinated tea or decaffeinated coffee if the patient would like to have tea and coffee. We advise her to have fresh fruits, diluted ones. We advise to drink at least 1.5 to 2 liters per day and to minimize the amount of alcohol she drank. All this helped with the bladder because all these drinks are irritant to the bladder, and once she reduces the amount of intake, they will feel a lot of improvement. The third line will be the role of physiotherapy. So any patient with stress incontinence, we refer her to physiotherapy. And the role of physiotherapy is to start with pelvic floor exercises. They have a specific program, which is usually the patient has to do about 8 contractions 3 times per day for about 3 months. And they can use different types of vaginal cones, and they have different programs to be suitable depending on the clinical condition of the patient. That's why the management of stress urinary incontinence is a multidisciplinary approach. So we will need the input from the physiotherapy, we will need the input from the bladder and bowel team. And there was a Cochrane review about the importance of pelvic floor muscle exercises, and they found that these women were 8 times more likely to report a cure after pelvic floor muscle exercises than those individuals in the control group. Even if the patient will opt for surgery at the end, still pelvic floor exercises and physiotherapy are very important to help in the cure. Then the medical management, which is duloxetine. However, duloxetine, it has a very limited efficacy in the management of stress incontinence. And it should be only offered to the women who prefer pharmacological management to surgical treatment or who are not actually suitable for surgery. And duloxetine has a lot of side effects, especially with memory. So it should be used with cautious, and a lot of drug interactions with duloxetine as well. Duloxetine was reported to cause hallucinations and can affect patients with mental health problems. That's why prescription of duloxetine need to be cautiously, and we need close review. We usually call them after 4 weeks of giving them a drug in order to see the impact of the medication on her condition, as well as to identify any side effects which need to be addressed quite quickly. And then the role of anti-incontinence devices, and again it's a poor evidence for this rule. In the market there are a lot of mechanical anti-incontinence devices, but again the rule is really not proven as an evidence-based. However, the NICE recommend its use when the leak occurred during exercises. And the most common mechanical anti-incontinence device is the ring pessary with a knob. And this knob will usually compress the urethra, and accordingly it will add as a cushion mechanism when the increase in the abdominal pressure, so it will block the urethra and the leak will not happen. And the last end will be the surgery, and surgery should be only offered after conservative management fails. So as I said now, any patient who present with urinary incontinence must follow this pathway. So first start with lifestyle modifications, then bladder diet, pelvic floor exercises, bladder and bowel team, and then if all of that failed, and you need to give them at least 3 months of physiotherapy. If no response, then we can go for surgery. And when you go for surgery, the patient need to have all the risk and benefit of different procedures, as we will see after that. For surgical management, we have three main types of operation, depending on the purpose of surgery, which will depend on the pathophysiology of urinary incontinence. For the first type, these are the operations which mainly directed towards the urethral sphincter, and they are either urethral bulking agent, and the most common type is Palcamid, or artificial sphincter. The other type of operation is the operation which is mainly to suspend the vaginal wall and so provide support, like corpus suspension, which is either open or laparoscopic, mid-urethral tape, which is either retropubic or transobturator, which was known as TVT or TOT. However, currently under the new regulations, there is a ban for the mesh use, and this ban now for almost 1.5 years due to the high incidence which was found of mesh erosion, or autologous sling, in which we use the rectus sheath as a sling to support the vaginal wall. Others which is no more recommended, which was bladder neck needle suspension. So if we speak about bulking agent, before the standard procedure for stress incontinence was the TVT and TOT, which was a sling procedure, and it was the gold standard for about 10-15 years until, as I said, the complication of mesh, or as we call it, the drama queen, which happens because of the erosion in the bladder and the bowel with high incidence. So we are now going to the bulking agent because we found that despite its effectiveness and durability is not as the TVT and TOT, but its safety profile is much better. So the indication of bulking agent is any woman who wish to avoid major surgery or mesh, or recurrent stress incontinence after failed primary surgery, or for those women who accept a lower cure rate in favor of less invasive, as Bulkamid is actually done as an outpatient procedure nowadays. So the patient can come for the clinic, have the procedure, and go home without even need to stay in the hospital. Or women who wish to have more pregnancy in the future. Different bulking agents exist since its development. There are silicone, there is carbon-coated zirconium beads or hyaluronic acids, etc., etc. And you will try different studies, either particulate substances or non-particulate substances, till we reach the bulkamid, which we are using it at the moment. The ideal bulking agent, it should be permanent. However, it's not existing because we have to do a repeat injection. We know that the efficacy is inferior to other surgical measures. We know that these bulking agents have poor durability. And that's why the NICE recommend written information to be given to the patient, including the name of the agent, the manufacturer, the date of injection, surgeon details should be given to the patient. And definitely all these procedures should be entered into the registry. So what is the mechanism of action of these bulking agent? It's all about improving the urethral closure mechanism. So the first mechanism of action is by improving the coaptation. As we know that these bulking agents are injected submucosal and they form a bleb. So this bleb will help to improve the coaptation of the urethral mucosa together. And it looks like similar to the submucosal cushion mechanism which is present before development of stress urinary incontinence. They provide an additional submucosal bulk, so they provide an artificial mucosal cushion, which improves the coaptation, improves the closure, and accordingly will reduce the incontinence. Another mechanism of action is they provide a central filler volume. So this actually can increase the length of the muscle fibers, and accordingly it will improve the sphincter power. As the ideal bulking agent, it should be easy to inject, maintain its volume, durable, and biocompatible, and its inflammatory and fibrotic changes are minimal. However, this ideal one is not existing. We have different bulking agents in the market, starting from non-particulate matter, which is the bulkamide, and particulate matter like silicone or carbon beads, calcium hydroxyapatite, and there were other agents which was present before like collagen and dermal implant, but they are withdrawn from the market because of the hypersensitivity reaction. We have two ways to inject the bulkamide, either transurethral or periurethral. There's limited evidence to suggest which one is better than the other. In general, the periurethral has less complication, as is associated with more early complications, particularly zero retention. However, it wasn't statistically significant. And there was a trial about patient satisfaction with bulking agent, and it was found that the mid-urethral injection has a better satisfaction than the bladder neck injection. Complication of bulking agent are not actually common. They are usually minor and transient. The commonest of them is the urinary retention and infection. Pain can happen, erosion can happen, periurethral abscess, hypersensitivity reaction, granuloma formation, pulmonary embolism, and death, but all these complications are quite rare. It was found mainly with macroplastic. It has high proportion of transient hematuria and dysuria. Also, infection rates and erosion have been reported to be as 6% and 1%. And abscess formation was reported with the use of microplastic and not with the use of bulkamide. There are other complications like injection site complication as sterile infected abscess, pseudocyst, mass formation, prolapse, diverticular formation, or detrosal overactivity. Again, it's all rare, but these complications were reported. For the procedure, 8 and 10 o'clock position. After injecting the bulking agent, you have again to drain the bladder. And to drain the bladder here, not to use a caster, because the caster can affect the bulking agent which you just inject, and accordingly the patient will have immediate failure. And don't use a cystoscopy to do that. Just a small in out caster will be enough to drain the bladder. And post-operative, the patient need to pass urine, and you measure the post-voiding visible urine, should be less than 100. Usually follow-up may not be needed. However, most of us will provide the patient with a phone call about 3 to 6 months after the procedure to be sure about the outcome. Most cases will need repeat injection after some time. There was a study which actually it was a big study which recommended a prophylactic second injection within 6 weeks of the first one. However, again, it's not a current practice to do that. So we do the first injection and do a follow-up 3 to 6 months after and see what the patient feel. And when we consent the patient for this procedure, they understand that they are not durable and they may need a recurrent injection. As any procedure, you need a preparation, and this preparation includes prepare the patient, prepare the environment, prepare your instrument, and prepare yourself. So prepare the patient, we have to do a urine analysis before that in order to exclude any urinary tract infection. Antibiotic prophylaxis can be given, however, it's not essential for that. The patient should be in lithotomy position. You will give her topical pain relief, like topical anesthesia gel, and you can inject local anesthesia around the urethra. And the injection device is similar to the dental syringe. Prepare yourself by having the proper training to perform that procedure. As the more you train, the learning curve will be higher, and accordingly the success rate will be higher and the complication will be less. Preparing the device for Palcamid, it is provided with a specific rotating sheath which will fit to the cystoscope. So you will get the bulking agent injection device. You get the syringe, you will remove its cap, you will fix the needle with its sheath, and then you will fix the rotatable sheath over the cystoscope. You make sure that the input and output channels are closed initially. You will need to rotate them to the 12 o'clock position in order to facilitate the injection, which will be at 6 o'clock position. Once you fix the syringe into the rotatable sheath, you slide it into a specific path, the specific pathway at it. You will introduce the stethoscope. You may need to evacuate the bladder before that, and it's easy to do that by retracting the optic stethoscope from the cheese. So the cheese will serve as a caster and the urine will come. And then you can put your scope back. You go inside till the bladder, and then you come out gradually till you can visualize the bladder neck, and then you will retract the stethoscope about centimeter more, so you are ideally around the mid-urethra. You will start with 6 o'clock position. You will inject by making the beveled end of the syringe directed towards the mucosa. You will inject submucosal till you have a bleb formation. Then you repeat again at 3 o'clock and 9 o'clock position. Other technique is to use 4 positions, which will be 2, 4. Thank you for listening. This video presentation was based on a recent article in the Obstetrician and the Gynecologist in April 2020. There are other videos on YouTube about Palcamid and how to inject it. Thanks.